Naka, and welcome back to Oceania Hospital's Health Talk. I'm your host Priscilla, and today we have a very familiar face back with us, Dr. Rakesh Adhikari, who is our interventional cardiologist and joining us for a second time on the show. How are you this morning, Dr. Adhikari?
I'm good, thank you. How are you?
Naka. So we're using this platform to go over important health topics, and what better way than to discuss it with the experts who live and breathe them every day. Before we begin, a big Vinaka Bakalevu to all our followers out there. Thank you for continuing your support, the likes, views, and subscriptions on YouTube and our other social media pages. Today we have Dr. Adhikari to discuss chest pain management and the role of the coronary intensive care unit, or CICU. So we'll just dive right in. Our very first question this morning, doctor. So chest pain can stem from various causes, some more serious than others. How does a cardiologist determine whether a patient's chest pain is cardiac related or not?
Yes, patient who presents with chest pain, it can be cardiac cause. There can be various non-cardiac causes as well. First and foremost, we take a detailed history from the patient, and we also look for the risk factors, whether the patient has a positive family history of coronary artery disease, whether the patient smokes, whether there are other comorbid conditions like diabetes, hypertension, or dyslipidemia. Okay, and we have to take a detailed history. So there are some clues in the history which goes more towards the cardiac chest pain. Okay, if the patient gives a history of chest pain which is more like chest heaviness, central, or towards the left side of the chest, squeezing, crushing kind of pain, and it may radiate to the left arm or to the jaws, sometimes to the shoulder, very rarely to the right arm or the right side of the chest as well. So these are more likely to be cardiac chest pain. Okay, and cardiac chest pain, it may be associated with other features like sweating. There can be shortness of breath, there can be nausea, and the cardiac chest pain, it increases with exertion. When the patient does heavy work, when the patient climbs stairs, and it relieves on rest. But if it is a severe heart attack, the chest pain can occur even at rest. Okay, so there are some other features like there are features which point more towards the non-cardiac chest pain. It is if the pain is localized to just a small place, patient points, I have a pain here. If the pain is very brief, if it lasts for less than a minute, for some seconds, okay, so it is less likely to be cardiac. If the pain increases on movement, or if the pain increases when the patient does some massage, or if the patient puts some pressure on that area, or if it relieves, it is less likely to be cardiac. If the chest pain occurs when the patient takes some spicy food or oily food just after intake, it is less likely to be cardiac. But sometimes a patient with heart attack, he may have abdominal pain which mimics acute gastritis or reflux. Okay, so if the pain occurs with coughing or in deep breathing, on movement, so these are less likely to be cardiac. And besides this history and the symptoms, and we have to also rely upon other investigations like ECG, cardiac enzymes. Sometimes we need to do chest X-ray because there are some conditions like which cause severe chest pain, central chest pain. It's a sharp tearing chest pain radiating to the back. It can be because of aortic dissection. It means the rupture of the main artery which carries blood towards the towards the whole body. And sometimes we need to do echo, heart scan, also to rule out that severe aortic dissection. Sometimes we need to get CT aortogram. So besides history, other investigations also help us in ruling out whether it is a cardiac or non-cardiac chest pain.
Thank you. So just going to move on to the second question. So I think we probably touched briefly on that on the first question. What are the most common types of heart conditions that require admission into the CICU?
Yes.
Or what makes this unit different from a general ICU?
Yes, the most common cardiac conditions which require admission in CICU is acute heart attack. So we call it acute coronary syndrome. It includes acute ST elevation MI, non-ST elevation MI, and also unstable angina. And there are other acute decompensated heart failure conditions. Okay, it can be because of heart attack or other valvular heart disease. There can be cardiogenic shock. It means the patient comes with a very low blood pressure, cold, clammy skin, and patient is short of breath. And it can and other conditions which need admission is if patient comes with cardiac tamponade. It means there is fluid around the heart which is causing too much pressure on the heart. Sometimes it needs to be drained with pericardiocentesis with a catheter. Sometimes there can be life-threatening arrhythmias, which means the heart rhythm can be very high, 200 to 300 or the heartbeat. So those are some life-threatening conditions. Sometimes there can be heart block. The heart rate can be very low. So in that case also we need to monitor in CICU. Sometimes patient also needs temporary pacemaker intervention. Okay, and basically CICU is similar to general ICU. The only difference is in CICU is equipped with some extra equipments and the drugs for the cardiac patients, and it is also looked after by a cardiac trained nursing staff and cardiologist. And general ICU and CICU are basically the same, just the difference in the manpower and those instruments. In general ICU, the patients of severe infection, some pre-op and post-operative cases, and some serious conditions related to the lungs or kidneys or liver, those patients are admitted in general ICU.
Okay.
Yeah.
Thank you. So for our next question, just can you walk us through the typical process from the moment a patient presents with chest pain at the emergency department to being admitted into the ICU, CICU?
Yeah, so whenever patient presents to emergency, so our aim is to do ECG within the 10 minutes of presentation. Okay, so besides taking, first we take a short history. While we are doing the ECG, we try to do ECG within the 10 minutes. We take blood samples, especially for cardiac enzymes, besides doing the routine blood investigations. And if there is a significant ECG change and we diagnose it as acute coronary syndrome, then we immediately treat the patient accordingly, according to the protocol, and we admit the patient to CICU. But if the ECG is normal, then we do the serial ECGs every 15 minutes or 30 minutes. And also we do the serial measurement of the cardiac troponin levels if the initial level is normal. Normally we do from the symptom onset, symptom onset to 3 hour, symptom onset to 6 hour, troponin samples are done. So if from the history we are not convinced it is a cardiac chest pain, the cardiac enzymes are normal, the serial ECGs are normal, the 6 hour troponin levels are normal, sometimes we discharge the patient to be followed up in OPD. But there are some conditions like even in acute coronary syndrome, so unstable angina means ECG can be normal, the cardiac enzymes are normal, but still it's a cardiac pain, then it is called unstable angina by definition. So even if those enzymes are normal, ECG is normal, if we are convinced with the typical cardiac symptoms, still we have to admit the patient and treat as unstable angina. And sometimes we need help of echocardiography, sometimes X-ray, sometimes if we want to rule out some other life-threatening conditions like pulmonary embolism, which means a clot in the arteries of the lungs, okay? Or if we want to rule out aortic dissection, means the rupture of the main aorta, in that case we need to do CT scan as well. Okay, so ECGs, cardiac enzymes, echocardiography, so these are the things we do in emergency. And if the patient has acute heart attack, ST elevation, MI, so we immediately counsel the patient for urgent angioplasty. Or if it is not indicated, then we admit the patient. And there is also another option of thrombolizing the patient. So it means if the patient comes with acute heart attack, the arteries are blocked, we see from the ECG and echo, we have the evidence, and we thrombolize the patient. It means we give a special injection to lyse the clot, and then we plan for the intervention.
Thank you.
Yeah.
So, sorry, we'll just move on to the next question. So, you spoke about intervention. In terms of intervention, how has the approach to managing acute coronary syndrome, such as heart attacks, evolved in recent years, especially in settings like Oceania hospitals?
Yes, this is a very relevant question, because what I have found is in past or still nowadays, I have found there is a concept that once patient has heart attack, so the intervention, angiography and angioplasty or stenting, it can be done within, immediately. So this is a misconception. So angiography and angioplasty means stenting. It should be done as early as possible. Okay, so throughout the world, the guidelines say if a patient comes with acute ST elevation MI, when we have evidence of chest pain and the ST elevation in the ECG, so ideal thing is to do emergency angioplasty immediately, okay, without wasting any time. If the patient presents to a PCI or angioplasty capable center. If the patient is presenting to a non-PCI capable center, so the aim is just to count the time, okay, if the patient can be transferred to a PCI capable center within 2 hours, so the patient should be given some tablets, okay, blood thinners and anti-cholesterol tablets, and immediately sent to those center. If the estimated time is more than 2 hours, then patient should be thrombolized. Thrombolized means there's a special injection to lyse the clot. And after thrombolysis, patient should be immediately transferred to a PCI capable center. Okay, so at our center also we are capable of doing both emergency angioplasty, and if the logistics doesn't favor, suppose a patient refuses immediate angioplasty, then we thrombolize the patient, and we are capable of doing angioplasty within 24 to 48 hours. So after heart attack, the message is angiography should be done and angioplasty should be done as early as possible. Okay, so there is no waiting period. There is misconception. People are waiting for 2 weeks. People are waiting for 4 weeks after a heart attack, and then they are coming for angiography. So the earlier the angioplasty is done, the more benefit. If we wait for that, maybe after 1 month a patient comes who already had a heart attack, maybe he won't have benefit, or maybe he might get harm after doing angioplasty. Okay, so at our center we are capable of doing, if a patient comes with heart attack, so we are fully capable, and we have been doing angioplasty or stenting within 24 to 48 hours of the admission. So this we have been doing, and because nowadays we have the latest generation stents, we have the latest antiplatelet drugs and anti-cholesterol drugs and other heart failure medications. We have the latest medications. So things have changed, the equipments, the hardwares, the medications. So those have evolved to a lot at this present era.
Okay. Thank you. Our final question, just for our viewers out there, what are some warning signs that chest pain might be serious, and when should someone seek immediate medical attention?
So this is a very important question, because same kind of, sometimes even if there is abdomen pain, there's a burning, so it can be mistaken as a acute gastritis, but it can be a sign of acute MI, acute heart attack. Okay, so whenever patient has chest pain, and if it is associated with sweating, if it is associated with nausea, lightheadedness, if the pain goes to the left arm, if the pain radiates to the jaws, and these are very alarming signs, it means you need to go and see cardiologist immediately, because it can be a sign of acute heart attack, and sometimes heart attack can be fatal, can be life-threatening. So if the pain is central, vague discomfort, and it goes to the left arm, it goes to the jaws, if there is sweating, if there is nausea, if there is lightheadedness, so you have to seek a medical advice. And there's one very important thing, like if a patient is diabetic, if the patient is elderly, if the patient is female, okay, so these typical cardiac symptoms may not be there. Even the person can have heart attack, but the symptoms may be just fatigue, just some shortness of breath and no chest pain. So that can also be a sign of heart attack. So if the patient is female, diabetic, elderly, even some mild discomfort or fatigue or shortness of breath, that should be ruled out whether it is cardiac or not.
Thank you. And that wraps up another episode of Oceania Hospital's Health Talk. Thank you again to our interventional cardiologist, Dr. Rakesh Adhikari, for taking out his time and shedding light on this topic that we have today. Before we end our show, just wanted to, again, a massive nakabakaliaw to all our viewers there. Please don't forget to like, share, and subscribe to our videos. And please, I hope that the things that we have discussed today makes you smarter in terms of heart health, and you also take this away and share it with your family and friends. So once again, Vinak Wakalia from Oceania Hospitals. We'll see you on the next episode.
Thank you.